Hi everyone, and welcome to our Atrial Fibrillation Awareness Day here at St. Luke's. I am Daniel Steinhaus. I'm a cardiac electrophysiologist here at St. Luke's. And I'm so excited you've joined us today to learn more about atrial fibrillation. We're going to go through several things today. First, I'm going to talk a little bit about atrial fibrillation so that you know what it is and what ways that you can reduce your risks. We're also going to have a patient interview so that you can hear from a patient that's also had these issues of atrial fibrillation. And then finally, we're going to show you a video of what our procedure lab area looks like and what our pre-procedure lab area looks like, so you know what it would be like if you came into the hospital to have a procedure. Before we start the presentation today, I want to remind you all that we have a chat box. So if you do have questions that come up during this talk, please put them there and we'll try to answer them later. So I'd like to start by showing you a brief presentation about atrial fibrillation in terms of reducing your risk, as well as treatment options and other things that we try to tell our patients that have atrial fibrillation. Today what we're going to do is talk about a couple of things. The first one is, what is atrial fibrillation and why does it happen? The second question is, how can I reduce my risk of atrial fibrillation? Third thing I will cover is, what are some important things to know about AFib? And what are the possible treatments? So let's start with the basic question of what is atrial fibrillation and why does it happen? Atrial fibrillation is a dysrhythmia of the heart. And it's important to understand that the heart has an electrical system inside of it, just like a house does. The normal electricity in the heart starts in the top chamber of the heart and then is moved down to the bottom chamber of the heart through a special wiring system. The nice thing about this wiring system is that it helps keep the heart in sync. So the top chambers will beat first because that's where the electricity starts, and then the bottom chambers beat after that because that's where the electricity goes. And when you feel your heartbeat, what you really feel is your bottom chamber pumping the blood forward. You don't really feel a lot of the other electrical activity within the heart. Well, what happens in atrial fibrillation? So in atrial fibrillation, the problem is that the normal heart's pacemaker system isn't really working anymore. And it's taken over by a funny heart rhythm where the top chamber of the heart goes very rapidly. So what happens is, instead of the normal electricity working, the top chamber is going very, very fast, and the electricity is still traveling down to the bottom part to give you a heartbeat, but in the top, it's very much out of sync. And so you can see on the top here is an example of what normal rhythm looks like, where everything's very in sync and it's very regular. And down below, you see an example of what atrial fibrillation looks like, where it's very out of sync and things are very irregular. So why does AFib start for people? Well, what happens is there are a number of different areas in the heart that can cause triggers for atrial fibrillation to occur. And the main ones come from this left atrial area, which I'm highlighting here on this screen. This is that back chamber of that heart of the left atrium. And you can see here coming off the sides of that, there are these four pulmonary veins. So you can see all four of these veins here sitting around the outside of the atrium. And those veins are draining blood back in from the lungs. I think of them as sort of straws coming into the back of a balloon. And where those straws meet the back part of the balloon, that's where the triggers for atrial fibrillation come from. So these areas trigger that atrial fibrillation to go out of rhythm in the top chamber of the heart. And that's really what drives it. And you can see here, we know from many decades of research that these areas of the heart tend to fire rapidly, as you can see in the top image there, and then that's what generates the atrial fibrillation. Atrial fibrillation really is a short circuit rhythm of the heart, where the heart is racing very quickly in the top chambers. And again, that drives the bottom chamber to go quickly because of the electricity that's conducted to the bottom. We know that the pulmonary veins, which we just discussed, are really the main trigger areas for atrial fibrillation, but there are other potential areas on rare occasions. So some of these areas can come from the right atrium, they can come from areas in the left atrium, they can come from areas called the superior vena cava. These are all other spots that that aberrant electricity can come from to trigger your atrial fibrillation. But again, the primary areas are those pulmonary veins. So why does AFib keep going for some people and why does it stop for other people? Well, what happens is really the triggers are the start of atrial fibrillation. And atrial fibrillation, once it's going, it's in a disorganized rhythm that's a short circuit that continues. And for many people, this will burn out after several minutes to hours, but for some people, it just continues. For people where it burns out, it's called paroxysmal atrial fibrillation, meaning that it comes and goes. But again, for some people where atrial fibrillation does not stop in the top chamber, those are patients that we call having more persistent atrial fibrillation, where they need other therapies to come out of it by themselves. So what are the impacts of atrial fibrillation? Well, the first thing is it increases your risk for stroke, which can be a major problem. The good news is we have treatments for that. The second thing is it can lead to congestive heart failure. What that means is the heart's not being efficient moving blood forward. That's because when the heart's out of rhythm with atrial fibrillation, the blood doesn't move through the heart normally, and so that can lead to inefficient heart pumping function. We know it is linked to premature dementia, and it also has a significant impact on quality of life, and we think that it slightly increases the chance of death. So what are the effects on the quality of life? And what do people describe when they have symptoms related to their atrial fibrillation? Some people have classic palpitations, and what that means is they feel their heart racing, skipping beats, or acting abnormally. Some people feel this often when they lie down at night, or they can feel it when they're moving around during the day. Everybody's a little bit different in terms of how they feel that, and some people don't feel palpitations. Other people get short of breath with their atrial fibrillation, so they feel that when they're exerting themselves, they can't do quite as much as they were doing before, and they get fatigued more easily. Some people describe chest pressure, where they feel tightness in their chest when they have their atrial fibrillation. Some people have difficulty sleeping, feel more anxious, and can even have some depression related to their atrial fibrillation. The reality is some people feel their atrial fibrillation, and some people really don't. Some people are very aware of palpitations, and we find that that's about half of patients. The other half may not have palpitations, but often have a lot of the other symptoms of feeling more short of breath, more easy fatigue, and just don't feel like they can do quite as much as they could do before. In terms of physical functioning, on average, people describe feeling about 24% worse than they did in their atrial fibrillation than without it. In terms of their social functioning, what that means is in their relationships and ability to go out and enjoy themselves outside of the home, they often will feel worse too. Mental health does take a hit with atrial fibrillation. It can be quite annoying to have it, and you feel like you can't quite enjoy life like you used to. And finally, in terms of general health, about 30% decrease in terms of how people feel in their general health when they do have atrial fibrillation. Well, a lot of people ask me, why did I get atrial fibrillation? So who gets it and why? Well, unfortunately, it's a very, very common problem in the United States and around the industrial world. About 25% of people that reach their 40s will have atrial fibrillation at some point in their lives. We know that this number is actually getting bigger, and in the United States right now, it's estimated to be between 5 and 7 million. That number continues to increase as time has gone on. Unfortunately, age is the most common risk factor, and there's not much that we can do about getting older, but it's important to be aware that this is a disease that tends to be more likely to happen as we age. And for men, it tends to happen a little bit earlier than for women. Other risk factors include things like age, as we talked about. Your genetics plays a role, so if you had family members that have had atrial fibrillation, you're slightly more at risk for having it. We know that other heart disease, like having old heart attacks or problems with your heart valves or congestive heart failure, are things that can also lead to atrial fibrillation. Sleep apnea has been something that we've identified more recently that can be a contributing factor. Sleep apnea puts stress on the heart while you're sleeping, and that stress on the heart can often materialize as atrial fibrillation. Diabetes can affect multiple organ systems and obviously has a strong impact on the heart. We know that diabetes can be related to atrial fibrillation. High blood pressure is another thing that we know that's related to atrial fibrillation. Obesity or being overweight, we know for every 5 points of above your normal BMI, your risk for AFib goes up by about 30%. Physical inactivity is also linked to atrial fibrillation, so people that are more active tend to be less likely to have it. And then alcohol, we have found that that is directly related to atrial fibrillation, so there's an 8% increased risk for every drink that a patient has per day. So what are ways you can reduce your risk? Well, I like to have this list of risk factors and try to separate it out into things that you can't change and things that you can change. So things that are tough to change, obviously, is your age. Can't get younger. We're all getting older. So not much to change there, but just something to be aware of. Your gender or your sex, we can't change that. So men, unfortunately, are a little bit higher risk for having AFib than women. The size of the top chamber of your heart does influence whether or not you could have atrial fibrillation. And again, that's not something you have a whole lot of control over, but sometimes by controlling other risk factors like high blood pressure, there are ways that you can prevent that from getting worse. Other cardiac disease, again, sometimes you don't have a lot of capability to change this. Things like valve disease or having old heart attacks or things like that aren't things that we can change, but we can treat the risk factors. And then the type and duration of atrial fibrillation is something that you can't really change right now. So some people come in presenting with sort of earlier AFib that we call paroxysmal, and some people come in with later AFib that we tend to call more persistent, as we discussed earlier. And there's not much you can do about that now, but sometimes it is worth thinking about should we act on atrial fibrillation earlier so that we can try to reduce the risk of it getting worse over time. Well, let's talk now about some things you can change. So obviously weight is something that we have the ability to change. For some people, it can be a challenge to do, but with diet, exercise, and sometimes other weight loss procedures, weight can be changed and can reduce the risk of atrial fibrillation. High blood pressure is something that we have a good opportunity to affect. We have great medicines for blood pressure now in the United States, and there are a lot of ways that we can help control your blood pressure. So that is something that we really should be working on if you have atrial fibrillation and high blood pressure. Control of diabetes is also very important because we know that better control of diabetes is associated with a lower risk of AFib. Alcohol consumption is another thing that we do have control over, and reducing alcohol consumption or even abstaining entirely from alcohol can be helpful for reducing your risk for AFib. As I talked about before, physical inactivity is a risk factor, so exercise is helpful for atrial fibrillation, both because it helps with weight loss and maintenance of lower weight, but also because exercise itself helps the heart be more efficient and again reduces the risk for AFib over time. Sleep apnea is something that we often look for in people that do have atrial fibrillation, and we know that treatment of sleep apnea can be helpful for reducing the risk of recurrence of atrial fibrillation. So what are the links between lifestyle and AFib? Well, unfortunately, lifestyle risk factors carry about a 50% burden of the risk of AFib. These are things, again, like obesity or excess weight, high blood pressure or hypertension, diabetes, and alcohol use. Those, again, are things that we all have control over, and there are things that we should be focusing on to help reduce your risk of AFib in the long run. One of the ways that we do this sometimes is doing what we call aggressive risk factor modification. And this was a plan that was put forward several years ago. This is just an example of one that some people might try. But again, it addresses some of these major risk factors. So weight management and exercise is addressed. We address your lipids. We address sleep apnea. We address hypertension or elevated blood pressure, and then we address diabetes. And by doing that aggressively and trying to control those risk factors, it really can make a big difference in terms of your AFib. I will also note down at the bottom there, it says smoking cessation and alcohol abstinence. We again know that those are things that are helpful for reducing your risk of AFib. For patients that were able to achieve these risk factor management goals, it resulted in a significant improvement in AFib episodes. For patients that were treated with this aggressive risk factor modification, only 20% of them had episodes of atrial fibrillation. For patients that didn't undergo this risk factor modification, about 60% of patients had episodes. So it's a dramatic improvement in terms of AFib episodes. Weight loss similarly has major impacts on your risk factors for atrial fibrillation and for the amount of AFib that you have. So for patients that were able to lose 10% of their weight, only about 10% had AFib episodes. For patients that could lose 3 to 9% of their weight, they had 30% of them had AFib episodes. And if patients had no significant weight loss or they had weight gain, again, about 60% of those patients had AFib episodes. So you can see that the more weight you lose, the better people tend to do. Well, what about exercise, and what are our recommendations for exercise? Generally, we think patients should be exercising for about 150 minutes of moderate intensity exercise per week. Typically, we tell people to break that up into 5 days of 30 minutes of exercise or 3 days of 50 minutes of exercise. Generally, we encourage people to do moderate level activity. So this means fast walking or jogging, sometimes riding bike or things like that. We know that intense exercise training can sometimes increase the risk of AFib. So that would be things like very high level endurance activity like marathon training, very long bike rides, and things like that. But again, sticking with moderate activity, we know that overall that helps reduce symptomatic and asymptomatic AFib episodes. It can also decrease your heart rate and your blood pressure, and people often feel improved in terms of their quality of life. This has been shown both for moderate intensity exercise as well as for things like yoga. These are all things that can help overall reduce your risk of atrial fibrillation. Well, what about alcohol? We know that alcohol does increase your risk of AFib, and we know that even 1 drink a day increases the risk of AFib. There's been some research, and people often are aware of this, that we think that a little bit of alcohol may help reduce some cardiovascular diseases, but that's not true for AFib. So overall, in terms of alcohol, what I recommend to patients is trying to get to 1 drink a day or less, or to abstain entirely in terms of their AFib. We think that those are the best options that we have at this time. So how do I think about risk factor management? Well, one schema is to use this ABCDEF for AFib survival. So that is alcohol and tobacco abstinence. B is for blood pressure control with a goal of under 130 over 80. CPAP for obstructive sleep apnea or treatment for sleep apnea. Diabetes with a goal to have your A1C, which is the marker for managing diabetes, under 6.5. Exercise, again, with looking to try to do aerobic activity or moderate intensity activity for 30 minutes a day for at least 5 days a week, with a target goal of getting to your heart rate of about 85% of your maximum heart rate. And then weight loss, looking at trying to have a heart-healthy diet and getting your BMI under 27 if possible. Well, I said I'd tell you what are some important things I like my patients to know about atrial fibrillation. The first thing I tell my patients, as we've alluded to a little bit, is that AFib tends to go along a continuum, and we tend to think about AFib as being a progressive disease, where the risk factors for AFib tend to predispose you to the triggers that start AFib. And as AFib in the early stages tends to be what we call paroxysmal. This isn't true for everybody, but generally this is the course that people follow. And when people start presenting with AFib, they will tell me that they'll have episodes that last for a couple of minutes or maybe a couple of hours at a time, and it'll burn out by itself. They'll go back to normal rhythm, and they'll feel well for days to weeks sometimes. What tends to happen is that tends to start being more frequent, though, and patients will then start telling me, gosh, I'm starting to have longer episodes, or now I'm starting to have episodes a lot more frequently, and they're happening a couple of times a week, and it's really starting to bother me more. Over time, what tends to happen is there are changes in the atrium that happen when the patient's in atrial fibrillation. And those changes in the atrium then allow more AFib to happen. So AFib then progresses and becomes more persistent. So then patients start going into AFib and not being able to come out of it by themselves. In that situation, often we need to restore normal rhythm by doing what's called a cardioversion, or shocking the heart back to normal rhythm, or using medicines to try to get the heart back to normal rhythm. Once that progresses, some people move on to what we call permanent atrial fibrillation, where in spite of all of our best efforts using medicine and cardioversion, we cannot keep people in normal rhythm. And again, this is a pattern that is pretty consistent for people. And what happens is we see the changes early on that lead to problems with the changes in the top chamber of the heart. And those then lead to more permanent atrial fibrillation over time. Another thing that I like all my patients to know about AFib is that AFib increases your risk of stroke. And this is probably the most important thing I can tell you about AFib. AFib is the most common contributor to stroke in patients worldwide. And unfortunately, stroke is sometimes the only symptom of atrial fibrillation. Strokes with patients that have atrial fibrillation tend to be worse than patients that have strokes from other causes. The risk for stroke in AFib increases with the risk of age, a history of high blood pressure, a history of diabetes, heart failure, coronary artery disease, or having a prior stroke. When we think about assessing your risk for stroke, we use this risk stratification system called the CHADS-VASc score. What that does is it helps us figure out how likely you are to have a stroke year to year, and it allows us to help you make decisions about whether or not starting a blood thinner medicine is right for you. The good news is there are many different things that we have that can help reduce your risk of stroke in atrial fibrillation. The main things that we have are the blood thinners, which are listed on the top here. There are other ways that we can reduce your risk of stroke that can be done either surgically or with other devices that I'll talk about a little bit later. In terms of the blood thinners, people often ask first, what about aspirin? Does that help me reduce my risk of stroke? Aspirin is a great medicine for some heart conditions, but it is not great for reducing your risk of stroke in AFib. So for most people that have atrial fibrillation, we do not really recommend people use aspirin as a stroke-reducing agent. We use more potent blood thinners, but the good news is they are very, very effective at reducing your risk of stroke. They reduce the risk of stroke by about 70% overall, which is a dramatic reduction with these blood thinner medicines. The anticoagulants that we have come in sort of two categories. So one is the classic one that's called warfarin or Coumadin. It's the oldest blood thinner that we have. It's been around for many decades. It works quite well, but the problem is it often can be difficult to keep people in what we call the normal blood thinning range for their warfarin. Unfortunately, it's affected by other medicines as well as by some foods. And so warfarin is often not our first choice anymore because we have newer agents. The newer agents that we have are these that are listed here. So dabigatran, rivaroxaban, apixaban, and edoxaban are all medicines that we use that are what we call oral anticoagulants. The good news with all of these medicines is they really don't need to monitor a blood level because they're very consistent in terms of their blood thinning capabilities. They don't really require any extra blood testing. They don't have a lot of interference with other drugs or foods. And there are reversal agents that are available. And so these tend to be medicines that are our primary go-to for people to reduce their risk of stroke. I will note, though, that when we're discussing blood thinners, we always work with patients to discuss what are the risks and benefits for the individual patient about whether or not blood thinners make sense for them and what is the right blood thinner. When we talk about blood thinners, we also think about, are there other ways that we could reduce your risk of stroke? And one of the other ways that we think about doing that are using devices. I have two of these devices pictured here. So on the left, you can see an image of what we call the Watchman device. You can see that in the heart there, it's implanted over on the left atrium, which is the side of the heart where strokes can develop. And where it's deployed is in this small area called the left atrial appendage. So you can see a little dog ear area coming off of that top chamber of the heart. And this device is implanted in that area to block off that area from forming blood clots and reducing the risk of stroke. We do think this works quite well. It is a procedure to implant this device. For most patients, we say, though, that if you're tolerating a blood thinner for right now, we recommend staying on that and leaving the device for patients that either don't tolerate blood thinners or have other bleeding issues. There are other ways to get rid of this left atrial appendage area, which is that dog ear area where strokes form in atrial fibrillation. And so those can be, that can be ligated surgically or actually externally from the body as well. So let's move on from thinking about stroke and how we treat stroke to what are the possible treatments for atrial fibrillation itself. Because while it's important to treat stroke, the other parts of atrial fibrillation are that it, again, impacts quality of life with the symptoms that patients have related to it. So we like to try, if we can, to try to reduce the symptoms that patients have. Classically, we divided this into two major categories where we said, well, one way that we could deal with your AFib is to just try to slow the heart rate down in AFib. And by slowing the heart rate down, the heart actually becomes more efficient, and we make it so that patients often feel quite well that way. But some patients, we discuss moving on to more what we call a rhythm control strategy. And what this means is that we're really trying, instead of just keeping the patient in AFib and trying to slow the heart rate down, what we're trying to do in this situation is we're trying to get the patient to go back to normal rhythm and stay in normal rhythm as much of the time as possible. The question is, which of these is right for the individual patient? And it's never totally clear, but in discussion with your doctor, we can often come up with very good answers for you. For rate control, as I talked about, again, what we're trying to do is we're trying to slow down the heart rate and just keep the top chamber in AFib, but make it slow that the bottom chamber isn't going quite as fast. When people are controlled, they often tend to feel quite a bit better because their heart's more efficient. And we commonly use medicines like beta blockers, calcium channel blockers, and digoxin are the main medicines that we use to control the heart rate in AFib. Rarely what ends up happening is that these medicines don't work, and what we can then do is we can go inside the heart and knock out the heart's normal wiring system between the top and the bottom. What ends up happening then is that the bottom chamber will definitely go slow, but it will go so slow that you would need a pacemaker, which I'll talk about in a little bit. The other way that we talked about treating AFib are using what are called rhythm control strategies. And these are where we try to restore normal heart rhythm and try to keep people in normal heart rhythm by trying to prevent the triggers that cause AFib. We predominantly reserve this for patients that are symptomatic with their AFib. We know that it reduces symptoms, and we think overall it may help reduce the risk of stroke, it may help reduce the risk of heart failure and dementia. Additionally, we think it may help improve your longevity. That's still a little bit up in the air. What are ways that we treat AFib? Well, again, thinking about all of these various different things, I'm going to show you kind of an algorithm that sometimes we use. And you can see that it's quite complicated. And so the thing that I wanted to just stress by showing you this is to say that it's very important to talk with your doctor about what are the right options for you, because there's so many different options that we have, and trying to figure out the right one for each individual patient requires a conversation. So again, this shows just again that it's quite complex, and we really need to individualize your care for treating AFib and thinking about what are things that we can do from a medical standpoint, what are things that we can help you do from a lifestyle modification standpoint, what are other risk factors that we can treat to try to reduce your risk of AFib in the long run. Again, going back to rhythm control, we often think about using medications for this, and then thinking about also using what's called cardioversion. Medicines are great for keeping the heart in normal rhythm, but they don't often get it there. So a common strategy is to try to use these medicines and then cardiovert patients to allow the medicines to prevent the triggers that come from the pulmonary veins or other areas, so we reduce the risk of going back into AFib. Unfortunately, the success rate with medicines is not amazing. It tends to be about 50 to 60%. Unfortunately, some people have side effects to the drugs that can limit their effectiveness, but a lot of people do quite well with medical therapy. Some people move on to having what we call atrial fibrillation ablation, and that's where we go inside the heart with catheters or other devices to try to find where these pulmonary vein triggers are coming from and try to isolate those areas. Overall, it's a procedure that we've been doing for quite some time. It's minimally invasive, so we go in through the veins in the groin. It typically takes between 3 and 4 hours. The outcomes differ again on the type of AFib that you have, as well as your underlying conditions. The success rate tends to range from about 50 to 90%. And serious complications tend to be a little bit around 1% or a little less, whereas other minor complications come up to about 3%. So let me talk about different ways that we think about doing ablation. So radiofrequency ablation is one way where we can go inside the heart to ablate the tissue. And what ablation means is that we're actually causing scar tissue develop outside of those pulmonary vein areas to try to trap the electricity within the pulmonary veins. We generate lesions by electrically heating the tissue of the heart. That thermal energy burns the tissue just like you could cook a steak, basically. The tissue is heated to a threshold where it actually causes damage to the cells, and the cells then create scar tissue. The problem can be that generating lesions can be limited by cooling inside the heart. So that can be one of the limitations, that sometimes radiofrequency ablation doesn't work well for deep lesions because there's cooling that happens from other structures around the heart. This is what it looks like to have a piece of the heart ablated. This is obviously from an ex vivo model, but that means that it's been taken out of like a dog's heart to show this, what it looks like to generate these lesions. But you can see here it generates a small amount of a lesion inside the heart. And it does it in kind of a small area in a very focused way. So this allows us to do very, very targeted ablation, meaning we can go in very, very small areas and just do very, very point-by-point ablation inside the heart. Again, it works really well, and it uses this heat energy mainly as the thing to generate the ablation. We have lots of interesting technology here where we use force sensing catheters to allow us to know how much pressure we're putting on the tissue when we're actually doing the ablation there. And it allows us to improve contact and make sure that we're getting the lesions that we want to get so that we create that scar tissue in a very focused way. Radiofrequency ablation, like I said, is very, very controlled, and it's got a great safety record. Another way that we can use ablation is to do what we call cryothermal ablation. So what this means is instead of using heat energy, we're actually using cold energy. This works slightly differently, but the ultimate result is really the same. It creates scar tissue around the outside of the pulmonary veins where those atrial fibrillation triggers come from. And by creating that scar around there, it traps that electricity inside those areas. It was originally developed for surgical application in the 70s, and in the 90s we started using it for electrophysiology procedures. In the last couple of decades, we've been using it with a balloon therapy called a cryoballoon that you can see down in a picture in the bottom here. And what it allows us to do is it adheres to the tissue, because when it freezes, it actually sticks there and creates scar right around the area, around the outside of that balloon. Overall, we think it works quite well. Very similar to how the radiofrequency energy works. One other way that we can do this that we don't provide here at St. Luke's, but other places sometimes perform this, is what's called laser ablation. And so for some patients, laser ablation can be used very similarly to the other types that we were talking about. This causes heating, and that heating creates scar. So what are the problems with using thermal energy, either heat or cold? Well, we know that it creates relatively deep lesions, which is something that we often want in atrial fibrillation, but we know that there are other areas nearby where we're working in the heart that can cause problems. And right behind where we're working are things like the esophagus, the phrenic nerve, the pulmonary veins themselves, and then there are other blood vessels nearby. All of those things can be affected by thermal ablation. We have ways of monitoring that while we do our ablation therapies. So during radiofrequency ablation and cryoablation, we have a very close eye on all of these things so that we prevent those risks. But again, nothing is risk-free. So those are some of the problems with thermal energy. One of the newer things that we have available to us in trials that we're doing here at St. Luke's is what we call pulsed field ablation. The interesting thing about pulsed field ablation is a totally novel approach to ablation. And we think that what it's going to do is help reduce any risk to collateral tissues, and it can just focus on ablating the tissue that we want to target, which is that tissue right around the outside of the pulmonary veins, without affecting things like the esophagus or the phrenic nerve. What it does is it uses very high voltage, short duration bursts of electricity. And what that does is it creates scar tissue. And by creating that scar tissue, then what happens is the cells inside create that scar right around the outside of the veins again. These all generate the same results overall, but they just work in slightly different ways. So this is kind of showing what the pulse field catheter and what that ablation looks like. That little purple area around the outside of the catheter there shows the electrical field where we're generating that tissue injury. So this is a little bit of a video of what that would look like. And you can see here the catheter being placed into one of the pulmonary veins, the catheter being expanded, being pushed closer to the pulmonary vein, being in the right deployment, right deployment area, and then the electrical field is turned on to create that area of injury right around the outside of the pulmonary veins there. Again, that traps the electricity within that area so that it doesn't get out to cause the AFib. Pulse field ablation seems like it's going to be very exciting, and we're very excited to have this technology in trials here at St. Luke's. It is something that hopefully will be moving towards actual commercial use sometime in the next several years. I want to address one thing that I said I would talk about before, which are, what about pacemakers? And I get this question a lot. Can pacemakers help my atrial fibrillation? Well, we know that pacemakers are very good at treating slow heart rhythms. Fast heart rhythms, like atrial fibrillation tends to be, aren't treated specifically with pacemakers. But sometimes what happens in atrial fibrillation is atrial fibrillation, when we treat it with medicine, can often go quite slowly. And sometimes we then need to put a pacemaker in to treat the slow heart rhythm so that we can treat the fast heart rhythm with medicine. This allows us to try to sandwich your heart rate so that it's not too slow and it's not too fast. One other thing that I talked about before is that sometimes we struggle using medicines to control the heart rate in AFib. And if that's the case, sometimes what we do is we knock out the heart's normal wiring system and allow a pacemaker to take over for the slow heart rhythm that would be there remaining. So pacemakers don't specifically treat AFib, but they can help us by treating by allowing us to give more medicine or do other procedures to allow us to control the heart rate in AFib in a better way. So this is what's called an ablate and pace strategy, and this is kind of an option of what that would look like there. And again, what we do is we knock out the heart's normal wiring system, so the top of the heart would stay in AFib, and the bottom of the heart is controlled by the pacemaker. Finally, I'd like to wrap up by saying that living a better life with AFib, there are many different components to that, and it's a team approach. And what it requires is an approach both with your doctor and thinking about what we can offer from a medical standpoint and other ways that we can help reduce your risks of atrial fibrillation in the first place. We are your partners in thinking about that, and it's important to think about having an individualized approach. So if you have questions or concerns, we are here at St. Luke's to try to help. We're so happy that you've attended this conversation with us today. I want to show you a little bit of some of our pamphlets that we have that talk about AFib management with our patients that are available here at St. Luke's. Now I'd like to introduce Dr. Jessica Klein, who is one of our new cardiac electrophysiologists here at St. Luke's Hospital. We're very excited to have her, and she's going to be interviewing one of our patients today so that you can learn more about a patient's experience who has had atrial fibrillation.
Thank you so much for joining us today. I'm here with Lori Jo Watson, who is a patient of Dr. Gupta's and underwent AFib ablation in January of this year.
I was diagnosed with AFib 10 to 15 years ago. I was experiencing, I suppose they're called heart palpitations, where my heart would start rushing for no apparent reason. I wasn't running or doing anything active. I would be either sleeping or working at my desk or walking, just doing everyday activities. And all of a sudden, I wouldn't be able to breathe as easily. My breath was a little bit short, and I could feel my heart beating really fast. And that's when I decided to go to a cardiologist. I'm thinking that was 2004. A couple of years after that, I I guess I had a stroke. And so I didn't die from AFib, but it did cause a stroke. And I was in the hospital 9 days because after when they were going to send me home after the 4th day in the hospital after having my stroke, and the AFib started up.
And can we go back to your ablation experience? How did you feel? Can you tell us a little bit about your experience in the hospital during the ablation?
So in January, Dr. Gupta performed a heart ablation on me in the middle of the month, and it went well. The surgery went well. I went home the next day. It was great. Took a few days off work.
And you said that you're feeling much better now. Have you had any episodes of AFib in the past few months?
I don't think I have. If I have experienced AFib, it went unnoticed. My heart rate wasn't at 200 going crazily, because I used to get short of breath and trying to climb hills, and it's so embarrassing.
What advice would you give to other people in thinking through their AFib in the years that you experienced AFib and finally got to this point of ablation?
I have a family member who is experiencing AFib, and I am trying so hard to encourage her to go ahead and make that appointment and get yourself taken care of today. You do not have to live with AFib. AFib is treatable now. Science and technology have come so far. In AFib, there's no reason you have to suffer and just live with it anymore.
Now I'd like to invite you on a tour of our EP procedure lab and our pre-procedural areas so that you can see what it looks like in the hospital and meet some of the people that would be involved in procedures here at the Plaza Hospital. Finally, I'd like to say thank you so much for coming. This video will be the last thing that we show you. And I'd like to invite you to come next year for our 9th AFib Awareness Day in 2023.
St. Luke's Mid-America Heart Institute offers the most comprehensive heart and vascular care in Kansas City, providing the full range of cardiovascular treatments and services. With more specialized physicians, experience, and innovative treatment options, St. Luke's is a pioneer in cardiovascular care and heart rhythm disorders. Atrial fibrillation, or AFib, is a common type of heart arrhythmia. It causes fast, chaotic electrical signals in the atria, leading to abnormal functioning of the heart. It also affects how much blood your heart can pump out to the body. Not that long ago, many heart conditions required open heart surgery. Today, the Heart Institute's expert physicians treat arrhythmias and other heart conditions with less invasive procedures. AFib can be treated with catheter ablation, a minimally invasive procedure performed by St. Luke's cardiac electrophysiologist or heart rhythm specialist. The compassionate care at St. Luke's begins the moment you arrive. Enter St. Luke's Hospital through the St. Luke's Marion Block Neuroscience Institute parking garage. Here, a screener will take your temperature and direct you to admitting. Shortly after check-in, you will be taken to a preoperative area where your care team will prepare you for the procedure. You will also have a chance to talk with your electrophysiologist. When the team is ready, they will transport you to the procedure area. St. Luke's highly trained cardiovascular team performs catheter ablation in a state-of-the-art electrophysiology, or EP, lab. Your safety and well-being are their top priority. The sophisticated equipment in the EP lab provides your heart team with the data and information it needs to perform the procedure.
During a catheter ablation procedure, a thin, flexible tube, or catheter, is placed through a small incision in the leg, where it's then advanced up through a vein and into the heart. There are 2 phases during a radiofrequency ablation: mapping and ablation. During mapping, an electrophysiologist creates a 3-dimensional image of the heart using specialized catheters in order to identify the area of abnormal electrical signals which may be causing the arrhythmia. In the second phase, ablation, the electrophysiologist directs a catheter to the targeted areas and delivers radiofrequency energy in order to create a small scar within the heart muscle. This will then block the faulty electrical impulses and restore normal electrical pathways in the heart.
Catheter ablations are outpatient procedures and usually take 2 to 3 hours to complete. After your procedure, The electrophysiologist will meet with you and your loved ones to share results and discuss next steps. Before being discharged, an advanced practice provider will provide specific at-home instructions, schedule a follow-up appointment, and answer any questions you have. We hope the information in this video is helpful as you and your loved ones consider treatment options and prepare for this procedure. As one of the top cardiovascular programs in the country, you can be confident that your heart is in expert hands at St. Luke's.